What I hope to present to you, regardless of what nation you're from, is a case study in what I think Eric would have called looking at a data set with the end users in mind, a case study of how data can be used to really influence policy. And it really was a partnership between our University Center for Excellence in Developmental Disabilities. We're part of the AUCD network. I realize that's a USA concept, but there are many interdisciplinary university-based centers, and obviously there are other nations have state or provincial intellectual disability agencies, and so I would really encourage this kind of partnership to really develop that kind of meaningful change. We were one of the earliest states, joined in 1998. At least 400 face-to-face interviews every year. We're not California. We don't do that many, but we also won't have that many people. I might also add just a little bit about Kentucky. I can't assume everybody knows about us. Maybe we're a Southern, maybe we're a Midwestern. We're not exactly sure what kind of state we are. We are largely rural. We have a high poverty rate. And we're good in basketball. So that's basically, and this is where I spent the great majority of my own life. So at any rate, that's a little bit about what Kentucky is. The data that we collect obviously provide two kinds of trends. They allow us to look at trends in our own state across years, which is very, very important, and also allows us to compare ourselves to national data. In 2008, we sampled solely individuals receiving services from our Supports for Community Living waiver. Now, what that is our Medicaid waiver for persons with intellectual disabilities receiving residential services. Some of the data I'm going to show you for Kentucky is very, very low. I suspect part of the reason it's very, very low is that the persons receiving residential services through our Medicaid waiver reflects some of our individuals with the most significant disabilities. That, however, in no way makes these data less meaningful. If anything, it heightens the importance of what we found. The Kentucky National Core Indicators Quality Improvement Committee was actually put together by our USED, and it was established at the request of our state DD agency to review and make recommendations for services. Our state was getting ready to develop some very significant revisions under a new commissioner, Dr. Steve Hall, to both our residential and our in-home Medicaid waivers, and they really wanted us to take a good hard look at the data and see what it suggests, the areas in which we needed to improve. This Quality Indicator Committee, and I think this kind of shows the power of asking university-based center to be involved, because it just did not include university researchers, and we included several different disciplines across the university. That's important, but it also included people who did the interviews, and some of our interviewers are themselves are individuals who have disabilities. It included staff from our DD agency, but most important, I think this is one of the strengths of university centers is that it include family members and self-advocates, because if they're not also looking at the data, you really don't have a very good lens of just how meaningful what you're seeing is, okay? We had a couple of things. I don't want you to think that everything is going wrong in Kentucky, so we asked ourselves what was going well, and then what are some critical strategic areas that we need to address. And here's just a couple of things. I just pulled that. There are several things that we actually were higher than the national. More of our individuals who were receiving our state residential waiver said that they participated in self-advocacy. In Kentucky, we had just about 50% compared to nationally 32%. So that was good news to share at the self-advocacy summits. We also found found, and I don't know if this is just the nature of our state, but that people felt safer, or less people felt unsafe. Only 16% of people in our state felt unsafe in their neighborhoods. Only 6% of people in our state felt unsafe compared to 16% nationally. So that was a good area. Here's some areas that we did not do well. One of them is, does a person have a job in the community? Actually, our data for people in our residential waiver was 18.5%. The data that we had for that year suggested it was 37% nationally, but what you just put up was about 16 or 17%. Yeah, so I guess maybe we weren't quite as bad there as we thought we were, but that's still a really critical area to focus on. Okay, in terms of employment, we set a goal. And we've instituted a bunch of initiatives, and we are collecting NCI data to determine if we are making that change. We don't have those data in yet. If they're not going up, I won't be invited back to do any other presentations. And we essentially looked at looking for a 5% increase in the next 12 months data cycle. And the data cycles, we're looking to determine it based upon the implementation of our new waivers. And obviously a job in the community refers to competitive or supportive employment. What did we do? Well, we used evidence-based policy decisions, not necessarily gold standard research, but the best available evidence of what would drive employment up. We revised our Medicaid waivers, made employment a priority in all spoken and written communication from our state agency, strengthened collaboration with the state voc rehab agency, and our University Center for Excellence was very much, essentially was the three of us together in that room coming up with many different strategies, including leadership training and more advanced training, consistently and clearly emphasizing employment outcomes, both on a systems level and an individual person-centered planning level, and then increasing the rate of hourly payment for supported employment, almost doubling it, while simultaneously reducing the reimbursement rate for day activity services by 11%. So trying to look at all of these strategies to create both incentives, training, and systems capacity. Health and exercise, and I'm sorry Beth Marks is not in here, but you know, we steal in the state of Kentucky. But one of the things that we found is that our folks who were reporting that they were getting at least 30 minutes exercise 3 times a week, only 12% of the people receiving the residential waiver in Kentucky said yes. National Core Indicator states said 19%, and you wonder who that 84% is. Well, the 84%, I personally think they were lying. We didn't know how good was good enough. And the whole question is, what is our standard? Do we measure it by how everybody else behaves? So we essentially, and this was published in a journal now known as Intellectual and Developmental Disabilities, did a survey of 500 random folks trying to translate the core indicator questions, those that would make sense to ask, you know, for you, to the general population. And so the orange bar corresponds to general population. So what it suggests, the people were telling the truth, neither our individuals nor persons in other NCI states were getting much exercise at all. But we also found that if you ask how many of our individuals were going out for exercise, at least in the past month, that would mean, you know, going someplace like a health club or gym or whatever, we were 23% compared to an average of 48% nationally. So what did we do about that? Well, we again set a goal, and I'm not going to read the goal to you, you can see it. We did several things. We created a new service, Community Access. Now again, this is all going into into play with the new waivers, and the regulations are just now at the point of being implemented. And it would essentially encourage citizens to become part of community life during the day, evenings, and on weekends. You know, when we looked at it, we kind of saw that what we were doing with our residential waiver was creating those isolated, supported living, and if you look at Kentucky, we don't have any residences of 4, 5, and 6. All of our residences are 1 to 3 people, but the problem is they're 1 to 3 people who are isolated, okay? So we're trying to build a community access service that would really begin to connect people to community. We increased both the rate of payment, and then we're currently implementing the Health Matters curriculum, Marks, Cicerek, and Heller. And I just want to say, I have been listening, and I want to point out that I was listening to Chris's presentation about combined capabilities, and the Health Matters curriculum, I'm putting a plug in for my fellow USED in Illinois, is a really good example of building both the internal skills and the health literacy skills of the individual through peer coaches who have intellectual disabilities, as well as supported environment by having mentors who also. So it's a really good example of what Chris is talking about. And what we're also. You didn't put my new slide in. Okay. Well, pardon?
It's in there somewhere.
Oh, okay. Well, it's in there someplace. Well, I'm going to tell you what my new slide said, because I'm not going to go. But at any rate, the other thing we're doing, and I think this is another power of a university center, we just did not do research. We said, okay, let's take some of our own funds, and let's set up a competition, an RFP from across the state, and we had like 33 different applications for mini grants to look at inclusive health and wellness opportunities. 33 agencies applied. We funded 8 of them. And what we're really trying to look at is best examples, everything from early childhood wellness programs to inclusive summer camps. One very isolated Eastern Kentucky County, inclusive gardening, really trying to look at some examples. And what I would suggest is university centers like ourselves have the capability not just to partner in research, but to partner in terms of self-advocacy, to partner in the context of training and technical assistance, and to partner in the context of model demonstrations, all of which to help create the change that is necessary. That was my slide. Now here's something that was deeply distressing to us. A consumer takes at least one mood, anxiety, behavioral, or psychotic medication, okay? And if you look at nationally core indicators, just a little under 50%. If you look at Kentucky, a little bit over 71%. And as a result, we set our initial goal there not at 5%, but immediate reduction of 10%. And some of the things we've done is we're kind of looking at, you know, are we medicating people because they don't have lives? And well, maybe what we need to do is ensure that they really are a part of the community, and community is not just what you do during the daytime. It's not a day program to go to. It's evenings, it's weekends, and what are we doing to connect there? And then oh, what is this going? Oh, okay. This is where my slides are. It's okay. I've already said that. Excuse me. All right. So, one of the, I don't know what's happened. Let me see if I can pull that up. I apologize. Well, I lost the things in terms of recommendations for medications, but some of the things different in that area was to focus on health screening, really looking at the need for medications. Another thing that we did was begin to develop much more intensive positive behavioral support strategies and reimbursement rates and training in terms of positive behavioral support. And really try to focus on getting that percentage down. That does not belong there. Okay. Now, another area that we really struggled with, and I think there's been a lot of stuff on this in this conference, and it is obviously a subjective measure of quality of life, is a person feels lonely. And we had strikingly high percentages of individuals who indicated that they felt lonely. 73% compared to 43% of the NCI states. Compared to the general population study that we did of just about 29%. We ask ourselves, what does that mean? Well, we have people living, 100% of our people in that waiver living in residences of 1 to 3 people. But if they're not connected to the community, then that's where that loneliness is coming from. Okay. Then we looked at, and this kind of comes to the notion of both qualitative and quantitative. This is one that you can measure. That by proxy. Does a person have friends who are not family and staff? And we found that in Kentucky, only 35%. Average of NCEI states, 73%. Okay. Our goal: increase the overall percentage of recipients who report having friends who are not staff or family by 10%. That was another one that we said in the first year we want an immediate gain. Okay. Some of the things that we've done to try to address that, getting out of day centers, participating in the life of their community through community access, increased funding not only for employment, for community access to clubs, groups, associations, churches, businesses, any things that our people are involved in. It's that whole notion that that was discussed, that unless you first have access to common activities, you're not going to have the chance to establish friendships. You're not going to have the opportunity to have shared lives. So we needed to take that first step. And while it kind of sounds strange to say the word shared lives in the context of increased reimbursement, and at least when you're trying to get supports in place, you have to look at both. The other thing that we have to make sure is the overall cost of new waivers, including those numerous changes, were not greater than the cost of the previous waiver. They were cost neutral. And so as we increased the rate of supported employment reimbursement, we decreased the rate for adult activity programs. Last thing I would like to simply point out is that all life indicators, whether they be subjective or objective, are important. And I'm one of those people who believe that the same indicators should be applied to people with intellectual disabilities that are applied to all of us. There's no essential difference in any of our lives. But one of the questions might be is, are there indicators that represent greater points of leverage? And this point has been made by others. It was made by Chaz. And yes, there are. And we found for that percentage, that 17 or 18% of people who were employed, we went back and looked at them. What did their loneliness index look like? What did their opportunities for friendship look like? What did their opportunities for health and recreation look like? In all cases, it was higher. And so I would suggest that obviously employment is a linchpin indicator. You move that one, in all likelihood, you'll move the needles of all the others. And as Dave Mank would say, and, much better than I would, it doesn't matter what the question is, the answer is a job. So at any rate, I am hopeful that all of the changes that we are making, that our University Center for Excellence, in both in its research, in its training, in its technical assistance, in its model demonstration, in collaboration with the state, will make a difference. That if I was invited back at some point to a later World Congress, that I would have better data to show you, and that this would be an example of what Eric was talking about, trying to take a large-scale data set, put it in view of the end user to make significant changes in people's lives. Thank you.